Hello, I am Dr. Kathryn. Welcome to this session on providing psychological, social and spiritual support. Next slide. So far in this course, we've learned about pain assessment and management, as well as assessment of other physical symptoms and communication skills, including how to break bad news using the SPIKES protocol. In this session, we will introduce other key domains of palliative care, which are psychological, social, and spiritual issues for the patient and their family. Next slide. Patients facing life-threatening and life-limiting conditions face suffering not only due to physical problems, but they also experience what we can call health-related suffering from the impact the disease has on their psychological, social, and spiritual well-being. To best relieve suffering and improve a patient's quality of life, we need to also consider these aspects of a person's well-being. We can call this providing holistic care. Next slide. It is normal for a patient to experience some degree of psychological distress in response to facing advanced disease. It may only last for a short time, or it may be intermittent, but for some people, it can be more persistent. We can do a psychological assessment by asking some simple questions to the patient. These questions could be, is there anything worrying you at the moment? How is your mood today? Or how's your mood been over the past few weeks? Are there things that you can enjoy and look forward to? And also, what helps you or what helps you through difficult times? And this can be people, so family and friends. It might be religion, or it could be hobbies or things that the patient enjoys doing. And we can offer those prompts. Psychological distress may be expressed in different ways. The patient may be sad. They may have feelings of guilt or anger. Sometimes patients respond with denial. And actually, this is a method of coping. So if a patient is in denial about what's happening, don't try to force that and allow them time to adjust. They just need more time. Other expressions of psychological distress may be anxiety. It may be withdrawing from social contact. It could be through frustration or despair. Some patients have mood swings, so their mood changes from one extreme to another. And sometimes patients might be agitated or restless. We know that psychological distress may be worse if the disease is progressing rapidly, if a person is losing their independence or mobility, or if there's been change to body image. For example, if the person has lost a lot of weight, so become cachectic. If there's visible, for example, tumor, so patients with head and neck tumors, or visible wounds, particularly if they're malodorous or having bad smell, or fungating and difficult for the person to adjust to the appearance of themselves with this type of wound. Psychological distress may also be worse if a patient does not receive the information they need about their illness. We know it also can be worse if there are uncontrolled physical symptoms, or if a person fears difficult symptoms such as pain or breathlessness as they get sicker. Poor communication or lack of follow-up by the healthcare team can also lead to psychological distress, as well as social issues in the family, which might be loss of job or role due to poor health. It might be financial difficulties, or it might be related to the stigma associated with disease. We know some patients are at higher risk for psychological distress, and that's if they have a history of mental illness, if they are isolated, or if they hide their emotions so they're not sharing how they feel. In addition, if patients have had other people in the family who have died recently, or problems in the family, either within relationships or other problems for the family to face, it may make the psychological distress or psychological lack of psychological well-being worse. Next slide. So how can we support patients that have psychological distress? We can do that by taking time to listen to the patient and provide them with the information about their illness. And we approach the consultation with a non-judgmental and caring, compassionate manner. We can recognize emotions and allow their patient to express them, as well as validating their emotions. We might say something like, "It is normal to feel this way when you are suffering from your condition." We know that by managing physical symptoms, this can help with psychological well-being too. We should tell the patient that we will follow up after we've started treatment for a symptom. For example, if we start some treatment for pain, we say we're going to see you again in 2 weeks to see how you've responded to this treatment. Furthermore, we should tell the patient that we want to follow up to see how they're doing more generally, and we should try and provide the patient with a contact in case they need to see you sooner. We can encourage the patient to change their environment, okay, especially for patients that spend a lot of time in their home or in their hut in the camp setting. They may be able to meet with friends or family. We know this can be good for their psychological well-being, as well as other activities such as listening to music or doing creative activities that they may enjoy. For some patients, psychological well-being can be supported through religious or spiritual rituals. And if you have access to mental health support or counselling or support groups, this might be helpful for some patients. Next slide. Depression and anxiety are more common for patients with life-limiting illnesses requiring palliative care. We need to think about depression or anxiety for patients who have more persistent symptoms, patients who are not distractible from their feelings or present with more severe symptoms. Symptoms of depression include a persistent low mood, loss of interest in everyday activities, a lack of ability to experience pleasure to things that would normally bring pleasure, which we call anhedonia. It may be expressed through feelings of hopelessness, worthlessness, guilt, or for some patients through thoughts of suicide or a desire for their own life to end. There are some tools which we can use which can help to identify patients with depression. An example of this tool is called the PHQ-9, but it's best to check which tool you are using in your area of work to identify patients who have depression. It's important to recognize depression as it can be treated, and doing so can improve the patient's quality of life. So management of depression. So as always, we try to make sure we've optimized the management of physical symptoms. We listen to the patient and provide any information they may need about their condition. We use the communication skills that were taught in the last session. If you have access to a mental health team or counsellors, you can offer the patient counselling support. Patients with moderate or severe depression ought to be treated with antidepressants, and selective serotonin reuptake inhibitors, or SSRIs, are usually the first choice. Patients with mild depression in palliative care can also be treated with antidepressants if we think it will improve their quality of life. Antidepressants may take up to 4 weeks to be effective and sometimes a bit longer. So we should monitor the response 4 weeks after starting the treatment. If there's been no response and the patient's still very depressed, we can increase the dose. Because antidepressants take some weeks to be effective, they're unlikely to be useful for patients in the last days of life because they won't have time to take effect. And we just need to be cautious using SSRIs in patients with peptic ulcer disease or bleeding disorders, as SSRIs are associated with an increased risk of GI bleeding. I've just provided here two of the common SSRIs that are often available. One is fluoxetine. So 20 milligrams would be a usual starting dose once a day. And if after 4 or 6 weeks there's been no response, the dose can be increased to 40 milligrams once a day. Or sertraline, we can use 50 milligrams once a day. And again, if after 4 to 6 weeks there's been no response, we can increase to 100 milligrams per day. And we advise the patient not to stop these medications abruptly. So for patients presenting with anxiety, we should listen to what they're feeling anxious about, to their concerns, and provide any information they may need about their condition. We should think also about other causes for anxiety, such as side effects of medication, such as corticosteroids, which can cause symptoms of anxiety. We can think about how we can help the patient with techniques to help them relax. And one of these might be sort of mindfulness, another one meditation, or we can teach the patient how to do progressive muscle relaxation, which is something you can read about and help your patients with. Some patients with anxiety will need medication to treat their anxiety. The choice of medication depends a little bit on the prognosis. So SSRIs are useful for anxiety as well as depression, but again, it requires the patient to have enough time for them to be effective. So a prognosis of at least weeks to months usually. We also have the option of using benzodiazepines for anxiety. And particularly these are useful if prognosis is shorter, so days to weeks, because we know that people can become tolerant to benzodiazepines. We can start them even in patients that have a longer prognosis for short periods if needed. So the most available benzodiazepine is usually diazepam, and this can be used as needed. So they usually come in 10 milligram tablets, so we can use a quarter of a tablet, so 2 or 2.5 milligrams, up to 3 times a day as needed for anxiety. Or we can use 5 or 10 milligrams once daily at nighttime. Next slide. So the patient is part of a family and also part of a community and part of a culture. So in palliative care, the unit of care is the family. We know that illness impacts the family, not only the patient. And similarly, if the family are impacted by the patient's ill health, we know that their reaction to it will have an impact on the patient. So this is interconnection between patient and family and patient. We know that ill health can have significant impact on people's social well-being in terms of their finances. This might be if the patient is no longer able to work and earn an income, or if the caregiver has to give up work to do caring duties for the patient. So it can have a significant impact on income generation for that household. The health problems can also have impact on education. Sometimes children need to stay at home and be caregivers. So families have needs too in palliative care, and it's important that we address these. These needs might be a need for information. So the family may need to know what to expect in the future as their loved one becomes sicker. They may need to know about prognosis so that they can plan. If there are young children in the home, they may need to be able to prepare the home and prepare the space for where the patient is staying, certainly towards the end of life, and think about how they're going to manage that. Often families and caregivers need emotional support too. We know that the patient and the family members will start the grieving process before the patient dies when they're suffering from life-limiting illnesses. They will start to grieve the loss of their health or their mobility or their independence. Family and caregivers also need support in their caregiving role. Caregiving will have a big impact on their life and their day-to-day living as well. Families also need practical support, and this might be support with how to provide basic nursing care to their loved one. It might be support on how to use medication for symptom control, or it might be a need for a referral to other organizations that can help with other types of support, whether it be finances, education, or equipment. Next slide. So when we think about spirituality in palliative care, we can think about spiritual well-being as a feeling of peace. Therefore, spiritual distress can be understood as when people are unable to find sources of meaning or hope, love or peace, comfort or strength, or connection in their life. This distress can affect their physical and mental health. Terminal illness can often cause spiritual distress in patients as well as their family and friends. Spiritual distress may be expressed in palliative care as a fear about the future, about dying, or what happens after death. It may express itself as a feeling of loss of identity or role, such as role as being a parent or being a worker for the household. Other ways are the patient or family member may start feeling helpless or feel a loss of control over what is happening in their life. Sometimes a patient may express their spiritual pain or spiritual distress through an overly strong physical symptom, and often this might be pain. So when patients are having very severe pain that's not responding well to analgesia, we should start thinking about whether there are other causes of distress that's making that pain experience worse. And that sometimes can be spiritual suffering, so we need to ask about that. Sometimes patients' spiritual distress is an exploration of what's been the meaning or the purpose of their life. And it's not uncommon for patients or families to break with their religion or cultural ties in these times, or they may have a desire to reconnect with past religious or cultural support. So both of those things can happen. Next slide. So we can use the acronym HOPE to support us with how to do a spiritual assessment for either the patient or the family. So we can explore a person's spiritual well-being. Some people may not want to discuss this, and we must respect that. And we should always share with a patient or family member that they do not need to answer any of these questions if they don't feel they want to. So using the acronym HOPE, we can ask the patient or the family member about their sources of hope, meaning, comfort, strength, peace, love, and connection. And we can do this with a question such as, what helps you through difficult times? We can ask about a person's connection to a religion, to an organized religion. So this is the O from the HOPE acronym. And we can ask, how important is your religion to you? And does it help you? So the P of the acronym is about the spiritual practices. So do you have spiritual practices which help you? And these might be, for example, prayer, it might be meditation, Or it might be connecting with nature. For some people, it might be going for a walk. And we also ask for the E, it's the effects of effects on their medical care and treatment. So we can ask about, has being sick affected your ability to do the things that usually help you spiritually? So what effect has the illness had on your ability to perform your usual spiritual rituals? Next slide. So we can offer spiritual support for patients. One thing, and I say it again because we've said it for each of the different dimensions of palliative care, we should just make sure that their physical symptoms are controlled, because it's very difficult for people to move on and to think about other issues if they're struggling with difficult physical symptoms. So we offer spiritual support for patients and families by listening to the person's story, and we show compassion. We avoid giving answers or advice, and that includes imposing our own beliefs if we have any, either religious or spiritual. We can use prompts such as, tell me more about that, or what does that feel like for you? It's important that we avoid false reassurance if the person talks about death and dying. Patients and families may find meaning and a spiritual connection through different things depending on the individual. For some people, it's spending time with family and friends. For other people, it might be creative activities or connecting with nature. For some people, they need support from within an organized religion or a spiritual leader. Some people are helped and feel reassured to know that these questions, the search for some meaning in what's happening to them and struggles, are actually experienced by many patients that are facing a life-limiting illness, and this can be helpful for some people to know. Next slide. So in summary, physical distress is one aspect of a spectrum of psychological problems, which can go on to be more severe and persistent, such as depression and anxiety. And it's common for patients facing a life-threatening illness to experience some degree of psychological distress. Palliative care provides support for families, of which the patient is a member. This support might be in the form of information, communication. It may be in the form of emotional support or practical support. And spiritual distress may impact on physical and mental well-being. It's important to listen and allow the patient or family member to identify what helps them in difficult times. Thank you.